Hi, everybody. I'm Cheryl Holden. All of my compatriots ditched on me, so I'm here by myself. They're everywhere. So this is the third talk on breastfeeding, and we'll be focusing on maternal conditions. And I don't usually do this, so I might be a little bumpy. Our learning objectives are to identify maternal conditions that put infants at risk for difficulty with breastfeeding, to differentiate the management of breastfeeding in the presence of various maternal disorders, and to have questions and answers about common breastfeeding challenges. Last week we talked about baby-friendly designation. We reviewed the AAP, the AAFP, and the ACOG statements on breastfeeding. Breast milk is the best source of nutrition for infants. Breastfeeding should be an exclusive source of nutrition for the first 6 months of a child's life and to be continue to be offered with complementary foods after that. The 10 steps we went over, and we're trying to stick to following all of them. We reviewed nutritional content of breast milk, readiness to breastfeed, and skin to skin. We discussed the demonstrated proper position and latch. So the two that were the most helpful was cross cradle and football hold, as far as that goes. Baby friendly, we went over all this before, just that it started in 1991. There's 10 steps that we at the hospital have decided to pursue this, and we're going to have somebody visit on June 26th to evaluate the hospital and how we are working towards the steps. We require all UMMC staff to support the 10 steps and to know how to access lactation resources. And if you don't know, see me afterwards so I can help you. This is the 10 steps. And then, okay, escape.
The objectives for this section are to identify how breast reduction surgery can impact breast milk production and state a strategy to assist mothers with inverted nipples.
Okay, nipple shield use is appropriate in the following situations. A, 2 hours after delivery and baby's too sleepy to latch on. B, mother is 26 hours postpartum, has flat, non-pliable nipples, and baby has not been able to latch on after repeated attempts. C, mother has said she got a nipple shield as a baby shower gift and wants to try it. Or D, mother says her nipples are normally more everted, but she had a long labor and has severe edema. Anybody have?
C is tempting, but I think the answer is B.
Yeah. Or go with B. It's B. So D is a close second. If we go back, I can't go back. It's a close second, but definitely the one we chose was the most.
According to the American Society of Plastic Surgeons, approximately 350,000 breast augmentations were done in 2007. As a provider, you need to know why the mother had breast augmentation. There are conditions such as marked asymmetry or hypoplastic tubular breasts where mothers have insufficient glandular tissue and therefore may not be able to produce sufficient milk. There are two anatomic maternal conditions that could affect milk supply. The first is when there is marked asymmetry between the breasts, as shown in this photo. The underdeveloped breast will most likely produce insufficient milk. An example of a situation like this would be Poland anomaly, with congenital absence of the pectoralis muscle. There may also be congenital absence of sufficient breast tissue. The other condition is when there is breast hypoplasia or tubular breast, as shown in these images. This is is defined by wide intramammary space greater than 1.5 inches. Little milk-producing tissue is present usually. The areola is more defined and larger than the rest of the breast tissue. Implants placed behind or beneath the pectoralis muscle has less potential disruption for lactation, but results in a more painful recovery due to the muscle being stretched over the implant. Implants placed behind the glandular tissue look more dramatic right away because they are closer to the surface and produce better cleavage. Inquiring about the reasons for breast reduction, also known as reduction mammoplasty, is also important. This may be done due to physical discomfort, cosmetic reasons, or post-traumatic weight loss, such as gastric bypass. There are several approaches to the surgery depending on how much tissue is removed. Breast reduction surgery can disrupt nerve supply to the areola and severed ducts, preventing milk from being removed from the breast. When the nipple is completely removed from the breast, as shown in the free nipple graft, there is the greatest risk to breastfeeding. I certainly have had women who have had breast augmentation or breast reduction who have successfully breastfed their infants. However, I've had some that have struggled. Studies have shown that women who had breast surgery were much more likely to have infants with poor weight gain or infants who required supplementation. It does seem that surgeons are now more aware of this potential problem and are trying to take approaches that are less damaging to the nerves, ducts, etc. These mothers will need closer supervision and monitoring. Interventions that might improve their chances to successfully fully breastfeed are to rent a hospital-grade double electric breast pump, pump after each or every other feed, monitor the baby's output and weight, and certainly consult a lactation consultant for follow-up. Breast first, supplement after. Now we're going to talk about inverted nipples and how it may affect breastfeeding. A normal nipple everts or protrudes out when compressing the areola between the thumb and forefinger. An inverted nipple inverts. It is estimated that approximately 10% of women have flat or inverted nipples. There is a classification of nipple inversion. There are different grades of nipple inversion, and the more severe it is, the more likely the baby will have difficulty latching on. Mothers with grade 1 inverted nipples can often evert their nipples easily. Women with grade 3 nipples are severely inverted and never evert. Even with the most severe nipple inversion, milk can still be extracted with a breast pump. Mothers with flat inverted nipples need extra attention. They need to get assistance from a breastfeeding expert if breastfeeding is not going well. They may need to pump, they may need to use a nipple shield, and they certainly need close follow-up. For difficult or persistent breastfeeding problems, experts suggest the temporary use of a nipple shield. A nipple shield is made of thin, soft silicone that doesn't interfere with nipple stimulation. There are holes at the tip that allow milk to flow to the baby. I would encourage you to avoid use in the first 24 hours after birth. Sometimes people will use nipple shields as a quick fix for latch problems, but really in the first few days, the most important thing is having people work with the mother to help her if she's having trouble latching. The nipple shield should be pre-filled with expressed breast milk. The mother should be observed and baby should be observed for milk transfer. It is important to stress that it is a temporary transitional tool, and as mother and baby become more comfortable with breastfeeding, the nipple shield should be weaned off. A hospital-grade breast pump may be needed for stimulation. At discharge, it is important to arrange for follow-up with a lactation consultant.
How to get it, stop using it, and get the baby to feed directly at the breast. It's trial and error. The best time that you can probably be the most successful is nighttime feedings. or if they fed a little bit, try pulling it off and getting the baby to latch on. I've heard of people taking 3 months to get the baby to breast. I've heard of people that have exclusively breastfed with a nipple shield. There isn't really any right or wrong answer. And I also have concerns about avoiding the use of the nipple shield in the first 24 hours. I think it's really mean to the baby if mom has inverted nipples or flat nipples for the baby to keep trying to latch and being frustrated. So I'm trying to support us using nipple shields up in labor and delivery if we need to. So, and if we can identify these things antepartum and let them know that they can come over and talk to us and learn about nipple shields ahead of time, that would probably really be cool too, because it's awkward trying to get it on and try to get the baby to latch. But that's a really good question. Sorry I don't have a definite answer.
We'll now move on to discussing maternal diseases that might affect lactation. The objectives of this section are to state 3 maternal diseases contraindicated for breastfeeding, understand which diseases are permissible with caution, and understand how obesity and polycystic ovary syndrome can impact breastfeeding.
Okay, another question. Which of the following maternal diseases is contraindicated for breastfeeding in the U.S.? A, hepatitis C, B, hypothyroidism, C, untreated active TB, or D, zoster outbreak on the leg? TB. C.
These are the maternal conditions that are contraindicated for breastfeeding in the United States, according to the American Academy of Pediatrics 2012 breastfeeding statement. First is illicit drug use. We will discuss this further on in our talk. Active tuberculosis. Expressed milk is okay, and breastfeeding is okay after 2 weeks of treatment, and the mom is no longer infectious. So again, expressed breast milk is okay, as it is respiratory droplets that transmits the active TB. Maternal HTLV-1 and 2, or HIV, as well as untreated brucellosis, are contraindicated. An active herpes simplex virus on the breast or active varicella 5 days before to 2 days after delivery. Again, because this is spread through respiratory droplets, expressed breast milk is okay. There is evidence of viral transmission of HIV, HTLV-1 and 2, CMV, and West Nile virus. CMV may be transmitted in breast milk, but rarely causes diseases in healthy-term infants. Very low birth weight preemies, however, are more at risk for symptomatic disease. Hepatitis B surface antigen has been detected in milk from hepatitis B surface antigen women, but does not significantly increase the risk of neonatal infection. Infants of hepatitis B positive mothers should, of course, receive HBIG and hepatitis B vaccines as soon as possible after delivery. Hepatitis C has also been detected in milk from hepatitis C virus-infected mothers, but transmission has not been documented in HIV-negative mothers. Hepatitis C infection is therefore not a contraindication to breastfeeding. Herpes simplex, not on the breast, may be transmitted via direct contact with the lesions. The mother must use good hand hygiene and cover any exposed lesions. Rubella has been isolated from human milk, but is not associated with significant diseases in infants. In developed countries, breastfeeding is not recommended in HIV-positive women because there are safe alternative feeding choices. However, in countries which lack readily available infant formula and clean water, it is recommended that HIV-positive mothers exclusively breastfeed for 6 months and then gradually wean to solid foods. In countries where infants are at increased risk for infectious diseases and nutritional deficiencies, exclusive breastfeeding may be their best chance for survival.
Do we have a question? Yes. And so that hasn't been added to the slide. This was made probably last fall, but that's very good. Did someone else say something? No? I'll make sure that we get that added. Thank you.
A little more about cytomegalovirus. Congenital infection is a primary concern. We've already discussed how infection via breast milk can occur but is not clinically significant for full-term babies. It is controversial how to handle CMV-positive mothers of premature, low birth weight or very low birth weight infants. Most agree that if the infant is less than 32 weeks gestation age, the mothers should be screened for CMV. Some recommend pasteurization and/or freezing and thawing of CMV-positive breast milk prior to use, and then observing the infant closely in the nursery. However, there are currently no prospective controlled trials to determine the effectiveness of this. Here are some maternal illnesses which may affect lactation. Maternal diabetes may lead to small or large for gestational age babies and transient hypoglycemia in the neonate. In addition, there may be a slight delay in the onset of lactogenesis. Mothers who are hypothyroid and are not controlled on their medication may also have delayed onset of lactation. Women with cystic fibrosis will have very salty breast milk. Monitoring a breastfeeding infant sodium level will be required. Breastfeeding after breast cancer is possible. A biopsy and/or lumpectomy may potentially damage ducts and nerves. Radiation therapy after lumpectomy may lead to insufficient tissue on the affected side. However, most women can breastfeed successfully on the non-affected side and may be able to breastfeed partially on the affected side. Postpartum depression can affect how a mother reacts to a baby's cues for breastfeeding. Finally, separation of mother and infant will certainly affect things. Many hospitals have policies that allow a breastfeeding mother who is admitted to keep her infant with her as long as there is someone else there at all times to help care for the infant. That way, mothers can continue to breastfeed if there's no medical contraindication. If that is not possible, a mother should be provided with a hospital-grade electric pump. Medications and breastfeeding will be covered in another talk. Approximately 1/3 of women with polycystic ovary syndrome will have milk supply issues, but most will be able to at least partially breastfeed. These women tend to have low progesterone and elevated estrogen levels, elevated testosterone, and poor breast development. In obese women, the initial prolactin response is diminished, so they may at first produce less breast milk. Even more important with these women, to provide frequent skin-to-skin, to assist with first breastfeeding, provide lots of praise and encouragement, and ensure that there is lactation follow-up after discharge. For any woman, engorgement can occur as the mother's milk is coming in during the first few days. Mothers are at risk when the baby does not empty the breast well, as is seen with a late preterm or very sleepy baby. Or it can occur with skipped feedings when mothers request her infant go to the nursery, where he might be fed a bottle or the baby is supplemented for a medical reason. Regular emptying the breast is important in preventing engorgement, as we see in these two mothers. The fullness can be so severe that the nipple becomes obliterated, making it difficult for the infant to latch on. There are two types of engorgement, physiologic and pathologic. Engorgement occurs during lactogenesis stage 2 when the milk production and volume of milk exceed the storage capacity of the alveoli. Basically, the body has no idea how much milk the baby is going to need, so it makes way more than expected, and then as the mother and the baby nurse successfully over the first few weeks, the body figures out how much it needs to make. Physiologic engorgement is a normal occurrence and typically appears around postpartum day 3. The mother may complain of breast fullness. Her breast may feel warm to the touch, and she may be experiencing milk discomfort and edema. This is more common in a primip. Pathologic engorgement, on the other hand, is an abnormal occurrence. The mother's breast will be very tight, painful, and hot to the touch. There will be poor drainage of her breast with eventual tissue damage. Pathologic engorgement is preventable. Treatment of engorgement includes frequent breast emptying, preferably by the baby, but a breast pump may also be used. Apply warmth prior to feeding. Some reverse pressure softening or pressure on the areola may make the nipple more protractile and temporarily decrease the edema in the areola. In some cases, hand expression of breast milk is the most effective temporary measure, or at least hand expression to soften the breast a little bit so that the baby can then latch on.
You're also recommending they use the manual breast pump or the electric pump if it's really gotten out of control as far as that goes.
Mastitis is an infection of the fatty tissue in the breast. Always consider mastitis in your differential for any breastfeeding mother who has flu-like symptoms. She may have localized breast erythema, swelling, and tenderness. Mothers with mastitis should rest, receive antibiotics, continue breastfeeding and/or pumping to keep the breast empty, and apply moist heat to the affected area. There is no danger to the baby breastfeeding on the affected side. Antibiotics should be chosen to cover skin flora. A mother with more than 2 or 3 recurrences of mastitis in the same site might need evaluation for an underlying mass. The most common complication of mastitis is early cessation of breastfeeding. Prompt treatment and support should prevent this. A mother with a plugged duct will present sometimes with a bleb at the tip of the nipple and a palpable lump. The mother should feed the affected side first. Engorgement can last a few days and can be treated by applying warm compresses before nursing to increase milk supply and cool compresses afterwards to decrease the swelling. While nursing, the mother should be massaging the area of plugged duct. Sometimes, using the back of an electric toothbrush with its vibrations can also help loosen up a plugged duct. Sometimes it's difficult to tell whether the problem is due to engorgement, plugged duct, or mastitis. This is a nice table to help you differentiate. Early onset of sore nipples is almost always due to poor latch and positioning. Ideally, we would get these moms positioned better before they have symptoms looking like this. Late onset of sore nipples, you might consider eczema or psoriasis if the mother has a history of this, herpes simplex virus infection on the breast, a candidal infection, mastitis, or vasospasm Raynaud's phenomenon. Management of sore nipples. The most important thing is to first correct the latch and positioning. If that still does not work, moist healing using a hydrogel pad, which can be purchased in the store, lanolin, or express breast milk on the nipples is the next step. Manual expression before feeding to soften the areola, or even pumping and feeding express milk until the nipples are healed may be necessary. Although there are many different creams out there for sore nipples, research has found that there is no specific topical agent shown to be any more effective than express milk applied to the nipple after a feed. Nipple shields may be considered in some situations. Candida may present with nipple pain, itching or pinkness of the skin, burning or shooting pain throughout the breast when the baby nurses. Predisposers include nipple trauma, antibiotic use, diabetes, or thrush or candidal diaper rash in the baby. It does not usually occur in the first few days after delivery. It is easier to treat earlier in onset than later. If you suspect a candidal infection, it is important to treat both mother and baby. Topical therapy is first line. Nystatin for mother's nipples and areola, nystatin oral suspension for the baby. Be sure also to look for and treat a candidal diaper rash in the baby. Oral fluconazole is recommended if the infection persists or seems deeper. Oral therapy must continue for 2 to 3 weeks. A single dose of oral fluconazole will not suffice. Mother should also wash all clothing in contact with her breasts and with her infant in hot water daily. Pumps, pacifiers, bottle nipples should be boiled daily during treatment to prevent reinfection. Next, we will talk about substance use in the breastfeeding mother. The objectives are to understand the effects of methadone on breastfed infants, identify which substances are contraindicated in breastfeeding, and understand that smoking is not a contraindication to breastfeeding.
On average, how many hours does it take for one alcoholic drug to be metabolized? 4 to 5 hours, it does not metabolize out but is trapped in the breast milk 2 to 3 hours, or alcohol is metabolized by the mother before it passes to the baby. Yeah, it's 3 for 3. That's awesome.
The American Academy of Pediatrics Committee on Drugs strongly believes that nursing mothers should not ingest drugs of abuse because they are hazardous to the nursing infant and to the health of the mother. Although marijuana is legal in several states, it is still discouraged to breastfeed while using marijuana. Marijuana, like these other substances and like alcohol, easily passes into breast milk. Methadone is deemed compatible with breastfeeding by the American Academy of Pediatrics. In a 2014 study of 124 infants, fewer infants in the breastfed group required pharmacotherapy for neonatal abstinence syndrome. They had delayed onset of withdrawal, a decreased need for medication, and shorter hospitalization than formula-fed infants. It is important that there is good maternal compliance in the maintenance program and that the mother has had negative tox screens for 12 weeks before and at delivery. This is a table with recommended interruption of breastfeeding times from Dr. Thomas Hale, Medications in Mother's Milk. Because marijuana is stored in the body fat, it stays in the body for a prolonged time. Pumping and dumping breast milk may not be as effective. Nicotine and its breakdown product cotinine do pass through into breast milk. It can increase somatostatin levels, which inhibit release of prolactin. It's important to weigh the risk of formula feeding against the risk of nicotine. The American Academy of Pediatrics says that if a mother is smoking less than 1 pack a day and smoking outside, they would still encourage mom to breastfeed. They do recommend that she delay feedings as long as possible after a smoke. Nicotine replacement therapy, bupropion and varenicline, are agents indicated for use as aids to smoking cessation treatment. According to the AAP statement of 2013, nicotine replacement therapy is compatible with breastfeeding as long as the dose, assuming a cigarette delivers around 1 milligram of nicotine, is less than the number of cigarettes typically smoked. Because nicotine passes freely into human milk and is orally absorbed as nicotine. Cotinine concentrations are lower than those related to tobacco use. Short-acting products like gum or lozenges are recommended. The infant exposure decreases proportionally with maternal patch doses. In contrast, bupropion is excreted into human milk with exposures that may exceed 10%. Although infant levels were not measured, there is a case report of a seizure in a 6-month-old partially breastfed infant that might have been related to bupropion. There's limited data about varenicline, but the varenicline label includes a box warning for serious neuropsychiatric adverse events, including suicidal ideation or behavior. FDA labeling discourages use of both bupropion and varenicline in lactating women. Alcohol is rapidly absorbed and passes readily between blood and milk. Infants spend significantly less time sleeping during the 3.5 hours after a maternal ingestion of alcohol. It's ironic that many years ago, women were told to have a drink of alcohol before nursing their baby at bedtime to improve sleep. Ingestion of alcohol should be minimized and limited to the occasional intake of less than 0.5 grams per kilogram, and nursing should aim for around 2 to 3 hours after drinking. In summary, breastfeeding is contraindicated for mothers who use drugs of abuse. Mothers who smoke can breastfeed but should be encouraged to quit. Alcohol should be used sparingly but is acceptable.
Click on the course Home button to mark this lesson complete and to access the next lesson.
In this module, we will use some case studies to expand upon concepts and material covered in other talks. Please make sure you have completed the talks on maternal medications and maternal conditions prior to starting this one. Case 1. Mrs. T has a history of moderate persistent asthma. She is on Singulair, Montelukast, and Flovent, inhaled fluticasone, 110 micrograms twice daily. She takes albuterol inhaler as needed. Mrs. T is having an exacerbation of her symptoms. She will need to take a short course of prednisone. Her baby, Jason, is 4 days old. He is a healthy term baby. LactMed is a free database through the U.S. National Library of Medicine. It is available online, or you can download the free app on your phone. Use LactMed now to determine if the medications Mrs. T is taking are compatible with breastfeeding. Alternatively, if available, you can use Dr. Thomas Hale's book, Medications in Mother's Milk, or his website, infantrisk.org.
And we'll just skip this.
Case 2. Ms. Brown just gave birth. While you are examining her baby, she mentions that she's concerned about breastfeeding. She reveals that she had breast surgery several years ago. She had an augmentation on her right breast and a reduction on her left breast because they were very asymmetric. You observe her breast and see an inframammary scar under her left breast and an anchor scar on her right breast. She says, "I can't squeeze a drop out of either breast. I know my baby is not getting anything." The best response is, let's have the lactation consultant start you on a breast pump and evaluate your milk production. Mothers who have just given birth often are concerned about milk supply. This mother has an even bigger concern since she's had breast surgery. Women who have markedly asymmetrical breasts may have a history of polycystic ovary syndrome, which may also affect milk production. The lactation consultant can show Ms. Brown how to express her milk by hand, as well as with a hospital-grade pump. Pumping, in addition to breastfeeding, will give Ms. Brown additional stimulation to her breasts to help establish more prolactin receptor sites. When her milk comes in, between days 3 and 5, we can evaluate how much milk she can produce. In the meantime, if the baby does need supplementation, the lactation consultant can advise Ms. Brown the best way to do that to reduce the likelihood of subsequent breast refusal. This mother underwent breast reduction surgery using the inferior pedicle technique on her larger breasts. The smaller breasts that had been augmented produced very little milk. The larger breast that had been reduced produced about half of the baby's needs. Mom ended up supplementing for the duration of her breastfeeding. She pumped both breasts 8 times per day, in addition to breastfeeding for about 2 months. Then she tapered off pumping and continued breastfeeding and supplementing. She was happy that she was able to provide at least partial breast milk feedings for 6 months. Case 4. This mother comes in for her newborn checkup. The baby is 6 days old. His birth weight was 7 pounds 8 ounces. He lost 10% of his birth weight while in the hospital. The mother reports a history of hypothyroidism and has been on Synthroid for 2 years. She is still bleeding heavily and is feeling tired and weak. You inquire about the feedings, and her baby is feeding on average 9 times daily. She was told to supplement after feedings, but hasn't been doing that regularly. The baby is having 2 scant meconium stools each day. He is now at 12% weight loss, and the mother says her milk has not come in yet. Her breasts do not seem full. You examine the infant, including a close examination of the infant's mouth. Everything is normal. His mouth shows no lingual frenulum. He should be able to transfer milk adequately. It is possible that this mother needs to have her thyroid medications reevaluated after her pregnancy. Hypothyroidism is associated with decreased maternal milk supply. The mother should have her thyroid levels checked and have her Synthroid dosage adjusted as appropriate. Alternatively, the mother may have a fragment of retained placenta that is secreting progesterone and preventing her milk from coming in. She should be referred to her obstetrician to have this evaluated and removed if necessary. If this is the case, her milk will likely come in spontaneously. In the meantime, the mother should be using a hospital-grade breast pump to set up prolactin receptor sites in her breast and supplement the baby to reverse his weight loss. You examine the mother's breasts. They are symmetric and of normal size and appearance. It is not likely a problem with hypoplastic breasts.
You can tell I'm a rookie. Okay.
This mother asks you, I'm going to my sister's wedding. Is it okay if I have a couple glasses of champagne? This is a common question from breastfeeding mothers. The rule of thumb is that occasional drinks are fine. Ideally, the mother should wait for 2 hours before feeding her infant after having a drink of alcohol. Remember that alcohol gets into breast milk quickly, but once it is out of the mother's blood and she is no longer feeling the effects, it is most likely out of her breast milk. There is no need to pump and discard breast milk. Case 6. This mother has returned to work after 8 weeks of maternity leave. She's been attempting to pump using a manual pump at work. She's having trouble finding a private place, and she isn't getting much milk when she can find a place to pump. She's distressed because she really wants to breastfeed and she can't quit working. So your advice would include all of the following except 1. Purchase an electric breast pump that will pump both breasts at the same time to save time and better maintain a milk supply. 2. Talk to your supervisor about locating a private space that you can use for 20 minutes or so, once or twice a day. 3. Feed your baby right before work and as soon as you return home. 4. Breastfeed in the morning and evening and don't bother pumping at work. 5. Pump twice while at work if possible. The fourth strategy, to breastfeed only in the morning and evening and not pump during work hours, may cause this mother to lose her milk supply. It would be helpful to purchase a more effective breast pump, one that will pump both breasts at the same time to stimulate prolactin levels better and help maintain a milk supply longer. Bilateral pumping also saves time. A mother may be hesitant to talk to her supervisor about pumping, but most women are surprised that supervisors can accommodate the needs of a breastfeeding mother, especially if they are educated on the benefits to the employer. Mothers will need less time off to take babies to sick visits, and women who are supported to pump at work are happier employees and less likely to leave their positions. The mother can feed her baby right before leaving for work in the morning, and again as soon as she returns home after work. If she can pump at work at least once, preferably twice, she is most likely to maintain a good milk supply. Regular milk expression is necessary for continued milk production. Residual milk and sustained pressure in engorged breasts leads to decreased prolactin after a few days. Milk supply will decline if a mother waits to pump until breasts are uncomfortably full. It is also important to know that the Affordable Care Act requires most employers to provide reasonable break time to express milk and a place other than a bathroom in which to do so. Hopefully, this mother will not have to remind her employer that it is her legal right to pump for her baby at work. The Affordable Care Act also has stipulations about breast pumps and lactation supports. It states that all new health plans must cover breastfeeding equipment and supplies for the duration of breastfeeding, and that all health plans must cover comprehensive prenatal and postnatal lactation support and counseling. Both of these services must be provided without cost sharing. Unfortunately, Medicaid health plans are exempt. Each state sets its own criteria.
Click on the course home button to mark this lesson complete and to access the next lesson. Okay. We're finished. Since we did this presentation, they've also come up with any federal buildings. I think the law happened last week has to provide a room for women to breastfeed or to pump their breasts. So I'm not sure how long that's going to take to happen, but here at the hospital, we only have one room for the employees. What were you saying?
I'm curious what will happen with the vote today and if that will affect that federal law coverage.
Well, even though we have the Affordable Care Act now, the medical assistance insurances switch up like every week. 1 week, AmeriGroup will say they'll provide an electric pump for mom. or Maryland Physicians Care, and then the next week they're saying no, only if they're in the NICU. So it changes with the wind as far as that goes. So does anybody have any questions? No? Okay, well, thank you for coming.
So, Dr. Fitzgerald and I got this on Tuesday. Is there a viral load level in hepatitis B that moms can't breastfeed at? I
really don't know. That's a great question. I'll try to look that up. But
we did a very quick kind of research, and there wasn't a clear answer. It seemed like there's some higher viral loads, at least from like up-to-date some other places that we looked at. There was some pause, but it didn't seem like there was a real hard line at anything. So it was certainly a learning point for me that day that comes to the work. I thought that efficacy in a high viral load was contraindication.
Well, I would think definitely in our preterm infants, they probably would ask the mom to pump and look into it before they would feed the baby. But I don't know the answer. What do you guys say?
Our neonatologist thing is.
Okay, good. Very good. Any other questions?
Where is this room?
The room is between the breast center and the cafeteria. It's in the learning center. To get access to it, you can either send an email to lactationsupport@umm.edu, or you can contact me. And it has a code lock on it. No, it doesn't. It's a card swipe. So we have to call the badge office, and we give every mom a year's access. If they need longer, they can just ask for an addition of time. Right now it has 4 of the hospital-grade pumps, and there's basically 6 stations. The money has been put aside to redo the room. I'm just not sure when that's going to happen. So, but it's it's busy all the time. And I think there should be one in the North Tower and one in the Shock Trauma Tower too, but I'm dreaming. And currently we don't have a place for visitors to breastfeed their infants or to pump their breasts. When I'm here, I bring them up to my office, but I've been told that there is no space. So maybe with the new labor and delivery, there might be a little room or something.
For visitors?
For visitors.
There is no room for visitors.
Yes.
On
No. Right now? You mean never? In the new ones also?
There is no room for visitors to pump in the current plans for visitors.
Okay. I was just saying maybe that might happen. I don't know. I've been asking for 12 years. Or if anybody has any good ideas of space that's not being utilized. We don't have a place currently. Thank you, everybody, for coming.